by way of introduction, some of you have probably seen me here before. My name is Michelle Rice. Most importantly, I'm a mother of 2 kids with severe hemophilia. I have mild hemophilia. I have been working in the advocacy space for 32 years. Before that, I was a lawyer and thought that was hard. And not a lawyer. I wasn't a lawyer. I worked in the legal profession and I thought that was hard, but advocacy is much harder. And for the past 12 and a half years, I worked at the National Hemophilia Foundation as their chief external affairs officer, overseeing their federal and state advocacy, stakeholder relations, and their payer relations team. So what I'm here to talk to you today about is healthcare coverage. And I'm pretty sure no one, when they're younger, grows up wanting to be an expert in health insurance. But as you guys know, you kind of get forced into it if you have a chronic disease, right? So I want to share with you some things that are maybe changing in the health coverage space, but also, a little bit about the different types of insurance, because that's going to become, it's always been important, but it's going to become even more important. How many of you get your insurance through your employer? Do you know if you're self-insured or fully insured, if the employer is self-insured or fully insured? I'm going to explain some stuff to you about that as to why that's important to know. But just let me give you some examples. There's a few different ways you can receive your coverage. There's private coverage, which is through your employer, through the insurance marketplaces that are out there. You can actually now you can, back in the day, we could have never done this, actually reach out to an insurance company or go through a broker and have them find you insurance. And I say in the past, you couldn't have done that because it took you all of about 2 hours from the time they get your application to come back and go, oh, denied, because they didn't have to take you before, and now they do. The other types of coverage, we have public plans. That's your Medicaid, your Medicare, your CHIP programs. And then you have other. And when I say other, it's like veterans coverage, tribal coverage, or even sometimes you'll have, like in the Amish community, they'll come together and have some kind of coverage together, but it's not traditional insurance. So those are the different types of ways that you can access insurance. And I'm going to tell you why it's important for you to know which ones you have. It's because not all plans are created equal. And this is where it's really important. So the difference between a plan that's self-insured or fully insured, for you as an individual, you're probably not going to know that just by looking at your insurance card. Because self-insured plans are where an employer is the one who's actually writing the bill or writing the check for your coverage, for any of the services you receive. So in other words, they may work with a company like United Healthcare. Your card may say United Healthcare, but what they've done is they've asked United Healthcare to do all of the administrative work for them, but then the bill comes to them. They write the check. So they're the ones who are at risk for all of the cost. And they pay a company like United Healthcare, which they call a third-party administrator or a TPA. They pay them just to do the administrative work and to let them use their network of physicians. One way you can tell is, do you guys have any of you have your insurance card on you? Okay, let me look at yours. On your card, a lot of times it will say, now see, hers says Blue Cross Blue Shield. But if you look, it will say, let me see how yours says here. The employee health plan provides benefits to you and your eligible dependents. Care First Blue Cross Blue Shield provides administrative claims payments only. That tells you you're on a self-insured plan. The reason why that matters to you is because your employer has a lot of say in what that plan covers. They use a United Healthcare's network, right? They may use their network of physicians, and they may even use a preferred drug list that United Healthcare has. But if that employer knows, for example, I know I have some people here who have bleeding disorders. I want to make sure those drugs are covered. They may say to the third-party administrator, I want to make sure you have coverage for these drugs included. Or, as I will explain to you later, they may say, we don't want you to have coverage for these drugs. The thing about self-insured employers is they do not have to follow all of the benefits in the Affordable Care Act. They are governed by the federal government, ERISA. They are exempt from some of those. One of the things is that they're exempt from is they do not have to offer the 10 essential health benefits that were guaranteed in the Affordable Care Act. What those are is ambulatory care, inpatient care, pediatric services, prescriptions. Odd that you would think that's an optional coverage, but it is. I say that they're not required to, but the majority of them have covered those services. But I'm going to talk to you about a new trend that's coming out where we're starting to see some of the self-insured employers starting to exempt certain drugs. So I'll talk to you about that. Do you want me to see on your card? Did you see? It's usually on the back. So it will say right up here. Anthem Blue Cross is the trade name for Anthem Vision. I believe yours looks like yours is probably a fully insured plan, which means the insurance company takes all the risk. So, and what you have to pay and what the employer pays is they pay just a premium. But the insurance company takes all the risk. So what happens is an insurance company will come in, meet with an employer, and they'll say, and the employer will say, what would it cost for you to just handle everything? They will look at like the history for that employer. What kind of expenses do you have? How many employees do you have? And then they'll do an actuarial risk analysis and say, all right, for a family, it's going to cost you this much per month. And for an individual, it'll cost you this much. And then they're the ones who take the risk. So let's say, you pay in $9,000 in premiums in a year, but you spend $100,000. The insurance company's at risk for that money, okay? Versus your employer being the one who pays that money. So most employers will set aside a certain amount of money. They know what their risk has been kind of historically each year, and they'll set aside a certain amount of money to cover their employee benefits, even if they're self-insured. They will set aside, on average, it's costing us about $200,000 per family or per employee. We've got this many employees, we're going to set aside that much money. Their risk is that it'll cost more and they'll have to pay for it. So again, the government recognizes that, gives them a little bit of flexibility in what they have to cover. So just kind of sharing that. Now, with respect to Medicaid and Medicare, are any of you on Medicaid or Medicare? Both? Okay. Well, just to look, as of April 2022, enrollment in Medicaid nationally is 88 million. Okay. Medicaid provides free or low cost coverage to certain classes of people, right? Adults that may be low income, children, pregnant women, elderly adults, people with disabilities. That last one, people with disabilities, I don't know if any of you have ever tried applying for Medicaid. I ran a chapter for the hemophilia community in Indiana for about 9 years. I could take in 10 people, their charts could say the same thing, and they would be like, you're disabled, you're not. You're disabled, you're not. I'm like, I don't understand that. It was very difficult for people with disabilities really to get covered, especially if you were an adult. Now, after the Affordable Care Act came out, that got a little bit easier because they required states, or they asked states to expand eligibility, and they increased the financial eligibility. So a lot of people were able to fall into Medicaid that way. And it didn't matter on verifying the disability. CHIP is, and it may be called something different in your state, but this is for coverage for children whose family income is too high for Medicaid, yet too low for them to afford going into the marketplace. Now, how many of you are familiar with what the marketplace is that came out from the Affordable Care Act, right? It's what it is it's a government, it's the government program for, they're private insurance companies, but it's established by the government. The plans within that marketplace have to cover all of the essential health benefits that are outlined in the ACA. They also have to follow certain rules about how high their premium or how high their out-of-pockets can be. So there's a lot of rules around that. And if you're getting coverage through there, there are a couple different kind of programs where you can get assistance, either a premium subsidy that brings your premium down each month, or in some cases you can even get some assistance that brings down your out-of-pocket costs for your copays and deductibles. So in order to be eligible for subsidies in the marketplace, you have to have your income has to be over 138% of the federal poverty level. So in some states, Medicaid goes all the way up to 138%. But in some states, it doesn't. It stops at 100. So if you're at 100 and you can't get any help till 138 and you're not eligible for Medicaid, you can get into like a CHIP program where they might charge you a small fee for doing that, but you end up getting Medicaid coverage. So I know this can be very confusing. If you guys have questions, we can do that. And then Medicare provides health coverage for people 65 or over, those with a disability. And then there's two diseases that are automatic qualifiers for Medicare, and that's end-stage renal disease or ALS. And those patients, it doesn't matter how old they are, they qualify for Medicare. So, pardon me?
I want to make sure that was working. I couldn't start the slideshow. It was not working that way.
Oh, but can they see this?
Yeah, they can see this.
Okay, good.
I was just
Okay.
it wasn't going to work.
No, that's fine. That's fine. So what I want to tell you is, oops, did I go? I think I went one too far. Oh, now I'm going the wrong direction. No, I am going the right way. Okay. So how many of you have already done if you're getting your insurance through your employer, how many of you have already had open enrollment for next year?
At the end of the school year.
At the end of the school year. And when is the end of the school year?
So our open enrollment is generally May.
Wow. Okay. So you've already had it for into
Right,
2023.
and then we start our new program September 1st. So September 1st through.
Okay.
Like you choose something else.
How about you?
Mine is the end of this one.
Okay. So I'm going to give you just from spending lots of years, my kids are 32 and 27. My oldest capped out on my husband's insurance when he was 4 years old. He hit his $1 million cap. So I say that only to tell you, I then went to a high risk pool. Now my son, as he's gotten older, has gone to Medicaid. So I kind of have experience in each one of these areas, and I'm used to talking to each of these types of companies. But I'm going to tell you, there's typical questions that everyone should ask when they're looking at their insurance, right? And then there's questions that those of us with bleeding disorders should ask. But the typical questions is, what are the plan benefits? And what that means is, what services are covered? And how are they covered? That's very important. If it's covered under the medical benefit or the pharmacy benefit. And the reason that's important is because that impacts how much you have to pay out of pocket. The other thing is, what about specialists? Do I have out-of-network services? More and more, there's less plans that have out-of-network services. And what that means is if you go out of network, in the majority of cases, they will not pay for that service unless it's an emergency, and they get to decide if it's an emergency. And typically that's kind of loss of life or limb. I can think of a lot of things that are an emergency that are in between those, but you would have a little bit of a fight to try to get those covered. How much does it cost? And it's important to not just look at what your monthly premium is. You need to look at, what are my deductibles and my coinsurance and my copays? What is my maximum out of pocket? That's going to be really important too. And again, for those plans that have in-network and out-of-network services, there will typically be a different cost share for the in-network benefits versus the out-of-network, even when it comes to your maximum out of pocket. If you're going out of network, it's usually higher, and in some cases, they don't even have a limit on out-of-network cost share. Then when I think about bleeding disorder specific, if you are taking Factor, is my Factor product covered? This is, to this day, the hardest question and to get the answer to. And the reason I say that is, I can call an insurance company and say, is my clotting factor covered? And you want to tell them the name of your clotting factor, right? So is XYZ covered? You know, here we'll say Novo 7. Is Novo 7 covered? You'll get a yes. Okay. Is that covered under pharmacy benefit or under major medical? My favorite is when they go both. Who decides, right? Typically, if they say both, typically it's that if you are inpatient, if you're in the hospital getting your infusion, or you're in an outpatient clinic getting an infusion, that's going to go under major medical. Because they make an assumption that when you're doing it that way, someone else is doing it for you. So they call it assisted, right? But if you're getting it at home, more and more insurers are moving that over to the pharmacy benefit. Why? It's easier for them to track and easier for them to restrict who you get it from. And I will explain why they do that. There is a good reason why they do that. It really is, you'd be shocked to find out the array of charges if they had 10 pharmacies and if they had out-of-network benefits. You would be shocked at the difference that you would pay from one pharmacy to another. Not maybe what you would pay, but what the insurance company has to pay. Huge difference. So that is partly why they do that. The other thing is my HTC, or if you don't go to an HTC, is my specialist in network? That's critical. Do I need a referral to see that specialist? That's also really important, because typically if you go one time and you go see him and you didn't get a referral, they'll forgive you once. They're not going to forgive you the second time. The second time they're going to say, well, that's not covered because you didn't get a referral. Sometimes you can get a referral that is for the whole year. Other times they may say you have to get a referral every time you go. It's important to know that. What services require prior authorization? Factor, it used to be that once a year, the beginning of the year, your doctor, when they do your first script, would send something to the insurance company saying, here's their diagnosis, here's the product. And you'd get a prior auth for the year. Now, there's a lot of them that are doing it, requiring it twice a year, sometimes once a quarter. And fortunately, I've only heard this with a couple of companies, they require it monthly. That is important to know too, because how many of you have ever gotten to a Friday and go, whoops, I don't have any Factor. I need to call and order some. Chances of getting a prior auth in one day is pretty slim. It's pretty slim. And then you're stuck without Factor over the weekend. So that's important. This is the new one. How many of you this year had something called a accumulator adjuster applied to your program, or an accumulator maximizer? What that means is how many of you, first of all, use clotting factor? Okay. Yep, your children. Have you utilized the copay assistance program that they have? Well, every month.
Well,
Okay, so here's the problem.
We do it at the beginning of January. It comes out of nothing for the.
We don't have to.
That is going to change.
Oh, okay.
And it has changed a lot of places already. What I mean by it's going to change is, because I did that for years. With the copay accumulator, which is the most common, although they're now switching over to the maximizer, and I'll explain that. But the copay accumulator, what they're saying is the accumulator, if you look in your definitions in your insurance plan, which how many people take the time to read all of that? Unfortunately, I've read lots of them. What that means is what you personally pay out of pocket. Personally is their key word, right? Because their belief is that if you pay something out of pocket and have some skin in the game, you will think twice before using the most expensive product, right? This is their way of really trying to get somebody to use a generic. Because a lot of times in the past, a manufacturer may only put out a copay card for their new drug, which is more expensive, right? That's not the case in hemophilia. In hemophilia or in bleeding disorders, all of the products have copay cards. So there's not a weird incentive for you to go to the most expensive. And by the way, we couldn't go to a generic if we wanted to. They don't have one, right? So here's the problem. What they've said now is you can use that copay card. And every month I'm going to use it. And once you get your prescription in January, they'll say, okay, here's your medicine. Your copay was paid. But at the end of that month, they reset your copay because you didn't pay it. The card paid it. So then you'll go and you'll use it the next month. We paid. Great. So we're all thinking we're good, right? Round about April or May, when you've hit your max on that card, because most of the cards have a max, they'll say, okay, well, here, we've got your script. You now owe $5,000 because you're going to owe whatever your deductible is. And a lot of people have high deductible health plans, right? So you're going to owe, they're going to say, okay, well, your copay is $4,000. I don't have that. Well, my favorite is they go, well, do you have a credit card? So I'm like, this is not good. So there are, right now, I think it's somewhere close to 50% of health plans, and it is more prevalent in self-insured plans, but it is also in fully insured plans that, they're using these copay accumulators. Now, if you had asked us 2 years ago, and I say myself and my colleagues 2 years ago, and somebody held a gun to our head, we would say, we'd rather you use the copay maximizer. What the maximizer does is, let's say your copay card from your pharmaceutical company says, we'll pay up to $12,000. They would then charge you as your copay $1,000 a month. Okay? So that when you use that card, you're still not paying it, but they've spread it out over time. All right? Here's the problem with that. The great thing that we used to love about using our copay card was it covered your whole out of pocket, your whole. So guess what? If I had to go to the doctor, I didn't have to worry about that. If I have to go, now you could get those other incremental costs along the way, right? But those are much smaller than what you get for your, right, for your factor. So a lot of them are switching to the maximizer. Then for those of you who are self-insured, there is a new program. And by the way, when they do these programs, they make it sound like it's a great thing for you. If you're reading your plan, it says, you are eligible for our cost savings program. It isn't cost savings to you. It's a cost savings to them. But it sounds fabulous the way they talk about it. So you need to be reading your plan language for this. The new thing that has started happening, and it's happened over the last 2 years, and when we first found it, and NHF was the first person to find it, my colleague was the first person to find it in a health plan. They're doing something called alternative funding models. That's what we call them, or we call them alternative funding schemes. Basically, what happened is there were some companies that created these new programs called, cost saving programs. And they would go to the employer and they'd say, we can help cut your pharmacy costs, not only for you, but for your employees. We can help them get their product for free or at a greatly reduced price. And I always tell everybody nothing's free, right? But here's what they do. They say, see these specialty drugs? You need to say that they are not covered. You need to stop including them on your preferred drug list. They are not going to be covered anymore. When an employee says that they need that medication, you send them to us. And usually you'll get a letter from your employer that says, hey, we have this great savings plan. Your product is no longer covered, but we've hired this concierge service that's going to be able to take care of this for you and help you get your drug for free or at greatly reduced price. Now, what they're really doing when you do this is they're trying to sign you up for one of the pharma company's patient assistance programs. And those programs were truly designed for people who don't have access. And so it's expensive. No one goes into business to give away their products, right? So what happens is, let's say you're using Nova 7 and you don't qualify. This company will then try to go somewhere else for you. Try to go somewhere, oh, we can get you this product instead. Well, maybe there's a reason I'm not using that product. What they've said to the employers is then if the person doesn't qualify, you could is the key word here, you could make an exception and pay for it under your medical plan. Now, when this program first came out, most employers did that because the employer doesn't want to hurt the patient. They really don't. They don't want to hurt their employees. Well, the problem is, think about it. Most of these employers got hammered during COVID. One of their biggest expenses is health insurance. And we all know how expensive our products are, right? So, gosh, that sounds lovely. I don't have to do this, right? I don't have to pay for this, but I'm still taking care of my employees because I've hired this company that's going to do this for them. Well, we've talked to a lot of employers and explained to them what really happens. These assistance programs are fabulous, but it's not the same as you being able to get your factor. You can't call them at the last minute and say, hey, I forgot to order. Can you send it to me? It comes from a different place, comes in a different way. A lot of times it doesn't come with all the supplies. So we're like, no, it's not exactly the same. We actually had a couple of success stories with a couple of two large companies who were like, oh my God, we didn't realize this is what this was. This isn't how it was sold to us. So they reversed it. But there are a lot of plans who are putting this in place. And the problem with it is, again, these companies will come to you and say, when you call them, your employer says, hey, connect with these people. You connect with them, they'll say, here, sign this power of attorney. It gives me authority to talk to any pharmacy on your behalf, any agency on your behalf, and it's like, no, sorry, not going to do that. And we've had where these companies have then gone back to the employer and said, oh, hey, we were trying to help so-and-so get their clotting factor therapy, or hey, we were trying to help so-and-so get their HIV medication. They've now outed them to the employer if the patient hasn't told them, which is a huge HIPAA violation. So again, it's kind of a shady thing. There are a couple of lawsuits trying to, in the courts right now, trying to get this overturned. My colleague, my former colleague, Colette Koulianos, who is still at NHF, is a bulldog on this issue. She has talked to the federal government, she's talked to legislators, she's talked to CMS. They are really working on trying to get this changed, but it is something you need to be aware of. If you get them sending you something that says, hey, we've got this new service, I would recommend you contact NHF. You guys will now have my number, but you can contact NHF as well and say, hey, can you help me understand, is that what this program is? And what does that mean for me? So it's just important for you to know those programs are coming out. And again, we are all working with employers to try to explain to them the real negative impact of these programs. So one of the things that I'm going to say is, and we're going to go down this a little bit more, and I know I'm probably going to run out of time. I put a little roadmap in here for you guys. One of the things at NHF that my former team worked on was we created a health insurance toolkit that explains to you how to evaluate your different health plan options. It also gives you all of the, it's got a glossary of definitions because insurance companies are a lot like the government. They love their acronyms. So there's a lot of acronyms in there. So one of the things I will tell you is take time to look at your choices. For those of you who get it through your employer, do you have more than one option of a plan to choose from? And is one a high deductible health plan?
No.
Okay, that's good. No. Well, you can, and I'm going to tell you too the difference between some of those, the HMOs, the EPOs. Yeah. Close. Health maintenance, or yes, health maintenance organization. Then you have exclusive provider organizations. You have, again, all these different names. I'm going to tell you, take some time, get all of the documents that you have, put them all together, get yourself somewhere quiet, download a copy of NHF's personal health insurance toolkit. In there, you'll find something that's what I call the personal health stat sheet. Basically, what that does is it looks at any benefit that typically has a cost share with it. So like your doctor visit, your specialist visit, your hospital visit. And it asks you, how many times in the past year have you done any of these things? And the reason that's important is we know if we're having a standard year, or we know if we've had a bad year, right, with our kids, or, so it's a way for you to do that. And then you'll see, it'll show you how to plug in the costs so that you can figure out what that plan is really costing you. Because sometimes the plan with the lowest premium isn't really the best plan for you. It may cost you more. So, and then I say, review each one of your plans for keywords like accumulator adjuster, maximizer. Always read the small print. Always look for, they'll give you like a little symbol. Okay, that's usually next to exclusions or quantity limits, those sorts of things. That's important for you to know. Then choose a plan, review it again to make sure. And don't just think about your child who's sick. Don't just think about their issues. Think about your own. I do this, I've been doing this for 32 years. And a few years ago, my husband's insurance changed. My kids were on different coverage. And quite honestly, I knew their coverage backwards and forwards. Didn't even think about my husband and I's coverage changing. And all of a sudden we get hit with a $10,000 bill. And I'm like, well, that can't be right. Go back and look. Well, yeah, there was a lot of changes in our copay. My husband's like, don't you do this for a living? Like, apparently not for us. I do it for other people. So it is important that you think about everybody in the family, including all of the doctors, all of, that information. So then what I want to talk about, because I know it's easy for us to point the finger and say, those horrible insurance companies. And look, let's be honest. It's not good for an insurance company if you're sick. It's not good for them if you're dying. They're not going to be able to sell their product to people if they're not being able to keep people healthy. So they really aren't just looking for ways to do this, but they have multiple challenges coming at them. Look, if it was just hemophilia, we would be a blip on their radar screen and they would never question anything for us. But there are hundreds and hundreds of specialty drugs right now that are hitting the market and have been for the last few years, and hundreds more coming out, plus gene therapies coming out. You're talking huge dollars. So they have kind of some of the same concerns we do, some of the same, things that they're worried about. And what they mainly talk about is high investment medications. When we look at hemophilia and we're expensive, but we say, you know what, it's a high cost, high impact, drug, may have a low prevalence rate, but it's still high impact. Well, again, you've got gene therapies, you've got cellular therapies, you've got innovative specialty. You heard Dr. Nugent talking about all the other new drugs coming out. What do all these have in common? They're expensive. And unlike in other businesses, one of the weird things is, in hemophilia specifically, when a new product comes out and it's more expensive, you would think some of the other products would go down in price. They don't. They go up too, every time. We don't know that. It's a whole other thing for us to battle on another day. I will tell you that. And I still, in my private business now, this is what I work on, is working with payers and working with pharma and working with providers. But I want to remind everybody, because it's so easy to get caught up in that big bill that we see. It's so easy for us to get caught up in everything that we're doing with our child or with our spouse or related to a cost, but there's no I in healthcare. And again, I'm going to remind you, if it was just hemophilia, we would be a blip on their radar screen. They wouldn't care about paying for these things. So they have to make their plans based on Joe average. And the key is, this is going to be me getting on my soapbox. Everyone has a responsibility to manage healthcare costs. We are in the United States. We have access to so much, but our health coverage costs more than any other country. We spend more in healthcare dollars than any other country, yet you're always hearing about people who don't have coverage. And here's the problem. And when I say we have a responsibility, meaning as a patient, if my insurance is going to pay for me to have this factor, it's expensive. I need to take it like I'm supposed to. I need to follow the rules with it. Because if I go, yeah, you know what, and my kids went through this, your kids will go through this, and all of a sudden they're invincible, they don't need it anymore, all of a sudden they're cured, they don't take it for a week or two, and guess what? They have a really bad bleed, now they have to treat for a whole week. Whereas if they've been taking their product regularly, they may not have had that happen. Those are the things that drive healthcare costs up. So it's important for us, if we're getting our medicines, use it the way we're supposed to. And you'll have the times where especially with kids, where they're not going to be compliant. But then when it comes time to reorder, only reorder what you need. Don't reorder a whole month if you don't need a whole month. So again, I will say to you that payers recognize this about us. It used to be that they said, oh, those hemophilia patients, they stockpile factor. Well, some people did. Why? It was people who had experienced a loss in healthcare at some point in time, or they had a family member who didn't have access, and so they were sharing their medicine. But now they said, we see that you guys are being very responsible. We see you're trying hard to be good stewards of your healthcare dollars. So then they're more willing to work with us. So I know I have other things on here that I don't think I want to chat about right now, because I'd like to ask you if you guys have anything particular health insurance thing that's come up for you that you were like, how do I fix this? Anything that's been awkward?
I can go out. So Right now I have, as part of a business that I own, I have a contract that also pays the healthcare, which is what the insurance is
Right.
right now. They have open enrollment. It was interesting that this is coming through because part of the open enrollment process is like, hey, we just want to let everybody know, everything has changed this time around, so make sure you review everything, and you're gonna get a new card in January. And of course, this person goes, okay, that's a concern. But because I own a couple of different businesses, we actually talked to the employees as well, and we were looking at, kind of doing our own business itself, and just getting away from that one contract side. But every time I hear this stuff, it just puts everything into a tailspin because you don't know what your steps are.
I'm going to tell you, if you wanted to go and become self-insured yourself, first of all, I'm going to tell you, you want to talk to somebody who's a really good person. And I say that a little tongue in cheek. And the reason I say that is you're going to work with a broker who's going to help you set this up. And I can tell you, I've worked with people who the brokers gave them incorrect information. And not because they meant to, they didn't understand it, right? I've also talked with people who have said, I told them, don't do it. For your business, it doesn't make sense. It's going to cost you too much, right? If you're self-insured, actually almost all, even fully insured plans will have stop loss coverage. That's going to be critical if you're self-insured. And what that means is you're going to agree to take the first $250,000 worth of risk on every one of your employees or every one of your insureds, right? And if they spend over $250,000, then it goes to the stop loss carrier and they pay it. So you have the cost of the insurance, but then you also will engage with a stop loss carrier who will charge you so much per person per month. And maybe that's only $5 per person per month. Maybe it's $10 per person per month. But I will tell you, they are very aware of hemophilia. Okay. And where are you based out of?
It's interesting because the healthcare market, healthcare.gov, there's no claims available.
Well, they're not available yet. You mean for an employer group?
Employer or personal, that's the problem.
No, the personal one. Oh, you mean in West Virginia because nobody is agreeing to do them.
Right.
I have somebody you can talk to who's a broker, and he does stuff nationally, and it's somebody I really trust.
Okay.
You could have conversation. So see me and I'll
Absolutely.
set that up. But again, being self-employed now, in January, I have to get a marketplace plan. And I, wanted to throw up a little when I saw how much I was going to have to pay.
Right.
However, I will tell you, even though I'm going to have to pay $800 a month for my insurance, I know that same policy to my employer is about $2,500 a month. So we get upset with our employer where we're like, oh my gosh, we have to pay this much. You need to understand it's a lot more that they're paying if they're paying a percentage of yours.
You're the company, which you're doubling down on everything.
Right. Yes. So just, I just want to share that, again, I say everybody has a responsibility. This is the pharmaceutical industry. Yes. Could we ask them to come down on prices? Absolutely. Payers, clinicians. And clinicians, I say this because, I'll hear people say all the time, I want to try this new medicine, but my doctor won't let me. Like, well, what was your reason? And I've heard at meetings before in our community, be like, well, I really like that rep. That's not a good reason to change because you need to know how much that's costing, right? They may be being nice to you for all the wrong reasons, just saying. Government. Look, what have we heard about for years and years and years, especially with Medicare? The government made it so we couldn't negotiate drug prices under Medicare. It's the stupidest thing I've ever heard. Why? In other countries, that's why they can get better pricing, partially because they have the ability, they have so many people covered. It's economies of scale. I can give you more business, give me a lower price, So government and then patients. And again, I just think it's really important to understand what is my prescribed dose? Am I getting that? Am I getting extra? Are they sending me more than I need? Those kinds of things. Because look, when I go out and talk to these parents, I'm like, look, I'll explain stuff that I've done with my kids. I'm like, how do we get more people to pay attention to that like you do? And I go, I am not unique in my community. I am not. I'm only unique because I get to get in front of you and have this conversation. But I'm telling you, I'm not unique. We know how expensive we are. And I can tell you, I am thankful every single day for the coverage I have. And if I can find a way to do it and take care of myself and do it for less money, I'm going to do it because I want you to keep paying for me. So, they are starting to understand that about our community. And so I just think it's more important that we continue to be diligent about that. What you're going to start seeing in your insurance plan is a bigger emphasis on if you want to change from one therapy to another, a bigger emphasis on, and especially if it's more expensive, is it medically necessary? And medically necessary is another one of those gray terms when you say, what does that mean? They'll go, well, your doctor will tell us. The doctor's like, well, okay, I already told you they need me. Yeah, but why? Why do they need to be on it? The other thing is, this has been, there's 17, well, no, it's more states than that. Several states have passed laws that ban step therapy. Step therapy is where it says you have to try this drug first, and if it doesn't work, then you can try this drug, and if that doesn't work, then you can try this drug. The problem is, if you have self-insured, if you're a self-insured employer, state laws don't apply in most cases to your plans because they are governed under ERISA, federal law. There are 17 states who have banned the use of copay accumulators. Okay, again, if you're self-insured, that doesn't help you. But NHF did get a bill introduced last year in Congress that would address it through ERISA plans. They are working to get it reintroduced by the end of this year.
We have that because we have a separate pharmacy benefit manager.
Yes, and they are the ones who do it. They are the ones who do it. Why are they doing it? Because most pharmacy benefit managers own their own specialty pharmacy.
Oh, yeah, they do.
And the only way this works, the only way a copay accumulator works, is if the person that you're processing it through is always the same one. So what they say is, we can do this for you, but you gotta let us use our pharmacy.
Yes.
Yeah.
What my son would use is, there's only like a handful of pharmacies that, it's a
Yep.
limited distribution, it's factor 10.
Yes.
So that's the.
Yes. So it's harder for them to apply
Yeah.
this, but they still will apply. You'll see more narrow networks where they start limiting the drugs. And then additional reporting. Some places may start saying you have to provide us copies of your factor infusion logs. So let's see. Again, what can we do as advocates? Read your plan, know what the requirements are, read it, make sure that that's the plan that's best for you. If you're not sure, call your treatment center, social worker, they can help you. Call NHF's policy team, call HFA's policy team. They can help you look at those and say, we don't usually tell you what plan to choose, but we'll say, hey, here's a red flag. Do you know this is in here? Do you know this is in here? So there are people that can help you do that. And for the clinicians, one of the biggest problems at NHF, we used to be able to say we had a 98% success rate in getting something overturned if somebody was denied. There was no magic. We weren't doing anything better than anybody else. It was that 9 times out of 10, the physician had not sent all of the appropriate documentation. So we would get involved. We would call the insurance company. What did they send? What did they not send? We would go back and we would get it overturned. We looked good, but it wasn't magic. So that's important to know. Again, if you're going through open enrollment now and you have questions, there's people you can call. I will say one of my biggest problems right now is Unfortunately, I'm not funded to do all this anymore. I have to do this. But that does not mean I've never turned anybody away. If somebody calls me, I'm gonna do my best to be able to help. But NHF has a policy payer relations team. HFA is very well-versed in policy. You can call your local chapters. You can call your HTC social worker or nurse. Yeah, so thank you. If you don't have any other questions, but I'll be around until later tonight if you think of something later.